So after kind of her subjective exam and understanding a little bit more about her aggravating and easing factors, here are some of the things that we're thinking of in terms of what are her primary kind of hypothesis or working diagnosis. Our first would be is hip and knee pain with movement coordination deficits. This terminology comes from the clinical practice guidelines published by the Academy of Orthopedic Physical Therapy, and really trying to identify some of the impairments as well as the overall condition that affects their movement. And so in this case, we would say hip/knee pain with movement coordination deficits in the nature of possible iliopsoas tendinopathy and compensatory tone in the extrinsic hip into the thigh and lumbopelvic musculature. Similar to this, if it wasn't necessarily kind of movement coordination, it could be more along the lines of power and strength. And in this case, we'd be looking more possibly along the pelvic floor dysfunction into the lumbopelvic SI, leading to soft tissue restrictions of the anterior hip and thigh. The biggest difference between these two is really the location of some of the pathology that may be going on. Is this kind of pelvic floor SI driving some of the motor control deficits, or is this really localized to the hip complex, leading to both the knee and the lumbopelvic? And then finally, maybe looking up the chain, looking at lumbopelvic radiating leg pain with neurodynamic mobility deficits. It's not uncommon for, like I said, hypermobility and persistent soft tissue restrictions to lead to further sensitivity of the neurodynamics in the lower extremity, especially in this case, that femoral nerve. So these would be three things that, as you can see, are related, but do have different origins of their ongoing symptoms. When looking at her overall irritability, pain is often what we see in the clinic as a primary thing, but in this case, we would say this is more minimal. It's usually within that 30 minutes of activity that it takes to kind of onset within 1 to 2 minutes to relieve. So it doesn't seem to be aggravated for significant amounts of times once it is aggravated. But also along irritability, I want you to think of strength. As we can tell that she has this limit of how long she can either stand or walk, and this is more along that strength is maybe a component of what brings on her tone or her symptoms. And then finally, what are the subjective asterisks that we're going to want to look at week to week or ask her about? This would be the sitting time, the standing time, and the walking time. Really the three primary aggravating factors as well as goals that she had mentioned addressing. Now, moving into kind of the next element of the exam, as we've developed our initial hypothesis, we've kind of gone through the subjective exam. Our standard elements would still include just a postural screen, regional screening, a functional assessment through combined planes of movement, and then also kind of looking at single planes of movement, either active, passive, and range of motion over pressures. When we look at differentiating elements, we'll often try to break things into two different primary categories. One being the mobility side of things. Is there a soft tissue mobility, tone or neurodynamics that may be affecting her overall nociceptive pain and symptoms, or is it more deeper at the joint level? And then if these are clear, if there's no true mobility restrictions, is there something going on with motor control, whether it be coordination, strength, and endurance? So based off of kind of where the patient is currently, I want to ask you a few questions before moving into your objective exam. One, what would be the functional questionnaire that you would have the patient fill out? Are there different body regions you would like to assess, anywhere from the lumbar spine? And then looking more directly at the hip, since this is her primary area of ailment, would you assess active motion followed by passive? Would you, given her irritability, are you willing to move into overpressures? And what planes would you like to look at of the hip? And then would you move into triplanar motions, including both Faber and Fader type positions? Additionally, looking then, what soft tissues would you like to assess? Are you going to look at the anterior and lateral hip, anterior thigh, abdominals, medial hip, posterior thigh, or other soft tissues? How about what joints and directions would you like to kind of further assess? Both the hip joint, lumbar, sacral, mobility. What are your primary areas that you think we need to clear? And then also looking at flexibility tests, kind of looking at multi-joint structures, including the anterior hip, we're looking at prone modified or prone knee flexion, as well as the prone modified Thomas test, posterior hip, anterior medial lateral hip, and then also prone Faber and anterior lateral hip of Ober's and posterior thigh at 90-90. And then if those are complete, would you go into a neurodynamic assessment, or at least expect to, based off of what she is reporting? Now, this is always important. We're just planning the exam right now based off of the patient's irritability. It does not mean that we will do all these tests, but having an expectation of what you would expect to see is always important, to kind of make your hypothesis align with what the patient is directly showing you. And then finally, also looking at what motor coordination tests you would perform. There's a slew of these, so I'll leave this as an open-ended question. Would you manual muscle test at mid-range versus at end range? Would you do an endurance testing, or are there any other functional tests you'd look at? And then finally, are there any pain provocation tests? Is there any areas that you are absolutely concerned about for ligamentous instability, etc. So looking at what kind of variables would you consider important, based off of what the patient has already told you, based off of their irritability, aggravating, and easing factors.